Okay, so I wanted to give this talk at about now because the other guys have done such a good job that I can only fail in doing this, so I apologize. But when it comes to personalized treatment, I would argue that myeloma is not as complicated as you may think, and I think it's probably rather simple, but we're not clever enough to see that simplicity at this point in time. And so what we all do is try and work out the key pieces so that if you can understand those key pieces, you might then be able to use them to treat patients. And so I'm very hopeful for the future, and the complexity will disappear as we understand more. But clearly when you're in the clinic, there are different groups of people where you should ask different questions. And so I tend to see quite a lot of younger patients. And really the question now is, how many younger patients can you cure? And so that's a provocative statement, but I think it's where the field is and where it will move to over the next years is optimizing cure. And by cure, you might think of people who are alive and well at 10 years and beyond after they've been diagnosed. And building on the number of people that get to 10 years and 15 years is really the way forward. And I think we start to have the tools that allow us to do that without damaging patients in the process. The elderly fit are another important group. And as Brian says, it gets increasingly difficult to know what an elderly fit person is, and where late middle age and old and decrepit come into the equation. And so sadly, Brian's at the late middle age, and I'm probably at the elderly and decrepit. But what is clear is that frailty and morbidity really make a difference. So when you hear people talking about treatment options, you really need to consider where they're coming from, because what's appropriate for, say, a 73-year-old patient that's had hypertension, high cholesterol for a decade or more is very, very different to somebody, the 72, been fit all of their lives, athletes. And so you really have to personalize the treatment based on those broad categories, and they remain the most important categories. And after the age of 75, your genetic risk groups makes not a jot of difference to your outcome. It's about whether you can tolerate the treatment and whether you'll take the treatment, because my experience with older people is they tend to know their minds. And if you say to somebody, you need a transplant, mate, they'll say to you, no, I don't, and I'm not going to have it, which again, I think is entirely reasonable. And so you've heard some great talks this morning, and what you need to think about is the body as an ecosystem in which, like a parasite, takes up home. And that parasite, say, is the myeloma clone, the plasma cells. So they develop in the bone marrow. They cause focal lesions in the bones. They impact your immune system, so you're prone to get infections, and they make your blood counts go low. So there are things with your macrophages, your osteoblasts, your bone-forming cells. The structure of the stromal cells that support them are different, and you disrupt your cytokine production. So the parasite alters your body so that it's at home there. So if you can get rid of the parasite, the body is more able to recover, and so minimizing the amount of disease in your body makes a huge difference, I think. And so you heard Ravi talk about MRD negativity. Well, part of my argument is that you should aim for MRD negativity, because when there's no cells there, there's fewer cells at risk of changing and becoming high risk, and there's less ongoing damage to your body, so as you can tolerate treatment if you do indeed relapse. So this is my representation of how myeloma develops. So each of these like bubbles represents the size of the cellular component. So sometime in your life, often years before you develop myeloma, one cell goes wrong, and that cell just lives. It's immortalized. And then because of the process of acquired mutations, changes epigenetically, and competition between cells, you select for the cells that grow best in the bone marrow and are best able to survive. And as the disease progresses, you ultimately get a large bulk of myeloma cells, and then you treat that, you kill off the sensitive cells, and you leave the more damaged cells to grow out when you relapse. But you shouldn't just think of it as the cancer cells. You have to consider what it does to your immune system. And as we move forward from this point on, now we have immune tools. And so all this idea of segmenting myeloma into different groups becomes interesting, because you no longer will rely on genetics or epigenetics. You need to look at, is the immune system functional? And can you engage the immune system to react against the tumor cells long term? And so that's where the daratumumab antibody will fit in. It's where new IMiD drugs will fit in, and it's where CAR T cells will fit in. And so this is all you need to know about myeloma. So you have a normal plasma cell. It goes wrong, it gets reprogrammed, and then it forms into this whole ecosystem. And it's understanding the behavior of the ecosystem with these focal lesions, extramedullary disease, that really is where we're aiming for. And so this describes that complexity, and these are different stem cell compartments that diversify as the disease goes on. And so you're not just treating one cell, you're treating multiple different cells. And Brian did a great job of explaining that and introducing this concept. And then he talked about resistance to proteasome inhibitors. Well, what old folk like me have learned is that if you want to treat a cancer, you don't take a single drug, which is why single drug combinations and doublets have largely failed myeloma patients over the years. It's because you have to use combinations of drugs that mop up all these different subcellular components and get the patient to the deepest remission. And so what is stratified medicine? So Ravi introduced the concept, and I'm going to try and develop it a little from where he went on. So the first box at the top is risk adapted. So you look at a patient and then you try and say, does this patient have really slow growing disease where we don't need to be aggressive with it? You can be rather more gentle and follow them over time. Or does this patient have disease that's going to behave like acute leukemia and needs these combinations of therapies? So that's really important. The second approach is this targeted therapy approach. It's largely mutationally targeted. So you look to see if the patient has a mutation, then you pick a treatment that targets that mutation. And so that is possible. There are examples in myeloma. The issue is the diversity of the ecosystem. And so diversity in the cancer cells is almost so extreme that when you put a selective pressure on it, like targeting a mutation, you'll select for cells that don't have the mutation. And so although you get responses, people relapse after 4 to 6 months. So it's of less use than you may have imagined. And the third component is response-adapted therapy. So what is MRD? Should that be the goal for everybody? So if you start to treat somebody with a combination, be it 3 or 4 drugs. If they have a poor response to that, should you swap to another drug combination that makes those people respond? And so you now see a stage where you have induction treatment, assess your response, transplantation, assess your response, consolidation, maintenance, assess your response. And if you're doing badly, you can increase the density of treatment, change the type, but get the majority of patients, be they older or younger, into a remission. But always be aware that there's a patient at the end of the needle, as it were, and you don't want to damage them. And a lot of damage was done to a lot of people by the use of Velcade, which left many people with intractable peripheral neuropathy, so that they, to some extent, their lives have been miserable. So this comes to the international staging system. So if you want to do risk-adapted therapy, how do you measure risk? And the answer to this is you can measure risk, but you'll be measuring it badly. And so the ISS clearly works, or this is the original version of it, clearly worked, but it was only good for comparing people in different trials. If you came to me in the clinic, I'd not be able to say you were high risk based on the ISS. So it wasn't really good for treating individual patients. So what we're trying to do is use the genetic abnormalities that Brian described so beautifully to segment patients into different risk strata and to use the ISS to improve our knowledge of patient frailty and susceptibility. So clinically, the translocation groups that you're interested in are the 414, which deregulates an epigenetic gene called MMSET. It has less lytic disease, it's more aggressive, and it's associated with IgA subtypes. The contrast to the 414 is the 1114, which deregulates something called cyclin D1. This is a relatively benign disease that hangs out for years and years, has more bone disease, and often expresses B lineage markers like CD20. The third group are these MAF myelomas, but it's a very small group, but 50% of them do really badly. And what's interesting is if you have that abnormality and you've got MUGUS, it's a good prognostic feature. So how do you understand that? So this is the FISH technology that Brian talked about. So you can improve the ISS by integrating knowledge on those genetic lesions, and you can make either this IMWG FISH or this revised ISS. But the groups between all of these things are really very variable. 40% of high-risk patients, it's a bit high. You're going to really treat those a lot differently. And what do you mean by high risk? So what people are talking about with these translocations are not really high risk. They're grades of risk. And so people with revised ISS3, 40% of them will be alive and well at 5 years. So why are you frightening patients at some level, telling them they have high risk when there's a 50% chance they're going to do better than a low-risk patient? And so we have to do better with these approaches. And that's where the sequencing technology that Brian talked about comes in. And so we're trying to move this field forward for the benefit of patients by using high tech. And so you sequence them, and there are some mutations that are associated with good outcome and some associated with bad outcome. The trouble is, these mutations only occur at about 4 to 5% of the total, so there's no certainty about their association with outcome, because you need to see groups of several hundred to be really using them in the clinic. And so we made this ISS mutation score, but I wouldn't dream of using that in the clinic because it's just not accurate enough. So we tried this other approach, which is get as many cases as you can with clinical outcome. So this was on 1,300 cases, all sequenced. But by the time you throw the over 75s out, you throw people where the data set's not complete out, you reduce down to about 700 cases. And so 700 cases with all the mutations and clinical data is good, but it was at one level a little disappointing for me, because most of these genetic factors just don't play out as you'd expect. But you can define in a group like this a small group of people who will not respond well to current treatment strategies. So the GP70 that Brian showed does this, but these driver gene mutations will do that. And so there's a group of double hit myelomas that are just characterized by either bi-allelic inactivation of P53 or amplification of 1q on a background of ISS3. And that's about 6% of the total. But these guys hit the baseline by 12 to 18 months. I mean, there's nobody alive really after that time. So for the first time, you have a very, very high-risk group that's easy to measure for people, where you could introduce a new type of treatment at the frontline setting. So you could do the test, and you could evaluate CAR T-cell therapy in these patients, because they just do so badly with current treatment. So it's actually a disappointing result for me, because I thought there'd be more markers. You know, we looked at 30,000 different mutations, and only 2 come out. But this is the one that comes out, so this is your chromosome 17p. And with FISH, there's probably 10% of people in the room who have got deletion of 17p, who've worried that they have high-risk disease and have been told that because the FISH shows deletion. But actually, 17p deletion on its own is a very, very poor marker of poor outcome. And you have to see 2 variants at that 17p, which is loss and mutation and inactivation of the gene on the other chromosome. This is chromosome 1, and again, there'll be a group of patients in the room that's probably even larger, that's been told they have gain of 1q and that it causes you to have a high-risk outcome. As a single marker, gain of 1q happens in 44% of people. It can't be a high-risk marker, because that would mean every other patient has high risk. But amplification of 1q, so more than 4 copies, really is a poor prognosis feature, especially if it occurs on a background of a high ISS stage. So it's shown in that chromosome on the left here. You can see multiple copies, like up to 18 copies of the same set of genes, and those really are deleterious to outcome. And to introduce us to imaging, which I think will come later, you can improve risk stratification by integrating data from PET-CT scans. So if you have more than 3 focal lesions, again, that can help you define a patient's outcome at presentation. Skip that. So here are the, at a broad terms, these are the mutations that characterize multiple myeloma. And so the next question becomes, can you do anything to target each of those mutations? And so this is a list of actionable mutations, where if you find a mutation, you can pick a treatment for it. And seen as RAS and BRAF are the most frequent mutated genes in myeloma, if you take a medicine that acts beneath that level, you should be able to kill myeloma cells. And the answer to that is it does work. It can be really very dramatic. Even if you've got heavily mutated, bad functioning disease, it will put you into a remission within a week. No, it's really that dramatic. The issue is, how do you keep those people in a remission because at the same time, they'll have cells that don't have that mutation, and they'll simply grow out. And so this is the concept of where you have this evolutionary tree of myeloma. And what you should really do if you want to kill myeloma is go for the roots, the things that cause myeloma. And so those translocations that were described really are the roots of the disease. So if you can target those, you should be able to kill everything. Whereas if you go for those changes at higher levels in the tree, largely all you're doing is pruning the tree, and then you allow it to grow back at some later time. And so all very wise and a lot of hand waving. Does it have any possible use in the clinic? So broadly, and it took me years to believe this, the 414 benefits from proteasome inhibition. So if you've got a 414 myeloma, maximizing your exposure to proteasome inhibition seems to be a good thing. And so in a world of carfilzomib, Velcade, ixazomib, long-term exposure and choosing the best proteasome inhibitor is probably good for these cases. There's some data that you can address P53 mutated cases. Chemo's not really the best, and in this modern world, I think we should move towards trying to get CAR-Ts approved for them as soon as we find these abnormalities. And some of the hyperdiploid cases are really good responders to IMiD drugs, and so can get people into remission, and you can maintain them long term. This is the stuff I told you about customizing treatment for RAS pathway mutations. If you're in a hole, if life's getting difficult, it is well worth trying MEK inhibition in this group of cases, because it can really work. The risk stratified approach, I think high-risk patients respond well to dose-dense chemotherapy, and what you shouldn't do is very high-dose transplants, and then you can't do anything for 3 to 4 months after the transplant because the bone marrow is frail. With high-risk disease, patients can relapse during that time. And so that tells you something about the biology of the regrowth of these cases. I think all of this field will be driven forward by venetoclax, which is a BCL2 inhibitor, brings us back to the beginning, and patients really can respond well if you have an 11-14 translocation. Most other patients don't respond well. There are other patients, but this is a pretty good marker for people who respond. You can use PET scanning to monitor response. So I would argue it's essential to do PET monitoring of the disease and to treat people until their PET positivity totally resolves. And this is just some data we generated in Arkansas to show that. But if you don't get rid of your PET lesions, you'll relapse very quickly. And just to show there's some balance in this, the French have found something similar as well. You have a worse outcome if you remain PET positive. And so I'll finish there and say, I think that personalized medicine has been with us for a while and will continue to become more and more important. And don't be put off by people saying myeloma is too complex for this. Everybody's different. Mostly, you can define about 6 subtypes of disease that are pathologically consistent, where you could try and place different types of treatment. And so I think the future is bright, and the introduction of bispecific antibodies and CAR T cells places the myeloma population on another big leap forward, where we'll need to understand more about the immune system. So thanks for your attention.